Statins. You've almost certainly heard of them. They're one of the most successful drugs ever made, a little pill taken by millions to protect their hearts. But what happens when that same life-saving pill triggers a bizarre medical mystery, one that causes a patient's own body to attack itself? Today, we're diving into an incredibly rare but really serious side effect that can turn the body's own defenders into destroyers. So first, let's just get the scale of this right. We're talking about millions and millions of people taking statins every single day. They are an absolute cornerstone of modern medicine for lowering cholesterol and, more importantly, for cutting down the risk of heart attacks and strokes. For the vast majority of people, they are safe and they work incredibly well. But this is where our story starts to get complicated. Just imagine this for a second. You're on a medication for years, no problems at all. Then, kind of out of the blue, your strength just vanishes. This quote is from a real patient who found that even simple things, like getting up from a chair, suddenly became a monumental struggle. And the weirdest part? It all started 4 years after she began taking her statin. And that brings us right to the heart of this mystery. A rare but severe condition called statin-induced necrotizing autoimmune myopathy. I know, it's a mouthful, so let's just call it SINM. But that long name actually tells you the whole story. Necrotizing means tissue death, and autoimmune myopathy means a muscle disease caused by your own immune system. So, in short, the drug triggers the body to attack and literally kill its own muscle. Now, a lot of you have probably heard that statins can cause muscle aches, and that's true, it's a known side effect. But usually it's pretty mild, and crucially, when you stop taking the drug, the pain goes away. But the question that defines this condition, the one you see right here, is what if it doesn't stop? What if you stop the drug and the weakness actually gets worse? That, right there, is the critical difference. So how in the world do doctors figure this out? Well, it's like a piece of medical detective work. They have to piece together all these clues from the patient's symptoms, from their blood work, and even from images deep inside the body, all to figure out what's gone so wrong. The first clues, of course, are the symptoms themselves. And we're not talking about being a little sore after a big workout. No, this is a deep, progressive weakness in those big muscles close to the center of your body. Think your thighs, your hips, your shoulders. It makes it tough to stand up, to climb stairs, to even lift your arms. And again, the key is that it just doesn't get better when the statin is stopped. So the next step is a blood test. And the results, well, they're like a dashboard full of flashing red lights. You can see on this table from a real case that a lot of the values are way outside the normal range. That's a huge sign of widespread inflammation and muscle damage. But there's one number in particular that tells a truly dramatic story. Okay, get ready for this. The key marker for muscle damage is an enzyme called creatine kinase, or CK. A normal level, that's usually under 135. Now look at this chart. This patient's level was over 13,000. That is nearly 100 times the upper limit of normal. A number that high is a massive, screaming signal that the muscles are breaking down on a huge scale. So what does that kind of damage actually look like inside the body? Well, this slide shows us exactly that. This is an MRI, and you see those bright white areas the arrow's pointing to? Yeah, that's not supposed to be there. That's edema, which is basically fluid buildup from all the swelling and inflammation. It's a crystal clear visual that the muscles are under a major attack. In this right here, this is the definitive proof, the smoking gun. Doctors can take a tiny piece of muscle, a biopsy, and look at it under a microscope. On the left, you can see necrotic or dead muscle fibers. And then on the right, that brown staining is highlighting the patient's own immune cells literally caught in the act of devouring a muscle fiber. It's just incredible. So we've seen all the evidence of the attack. We know what's happening. But that just brings up an even bigger question. Why? Why is the body doing this to itself? To answer that, we really need to understand the autoimmune trigger. The final diagnosis is SINM. And the most important word in that whole long name is autoimmune. It's not the statin itself that's directly poisoning the muscle. Instead, the statin is just the trigger. It sets off this terrible chain reaction that causes the immune system to just go rogue. Here's a pretty simple way to think about it. Imagine the statin shows the immune system a training photo of something it should attack. But in this rare case, the immune system makes a mistake. It thinks the photo is of a dangerous intruder, but it's actually a picture of a normal, healthy part of your own muscle cells. So, the immune system creates these wanted posters, antibodies, and starts hunting it down. The real problem is, even after you stop the statin and take the training photo away, the body's security force keeps using that wanted poster to attack its own healthy tissue. So let's just put it all together, side by side, because this comparison is so important. Your simple, common statin muscle pain goes away when you stop the drug. Synam, on the other hand, is a whole different beast. It's extremely rare, it's severe, it sticks around long after the drug is gone, and you need some powerful immune-suppressing treatments to stop it. And that's the key, because the enemy isn't the drug anymore. It's the body's own overactive immune system, so the treatment has to be completely different. You're basically fighting an internal battle, trying to calm that immune response down. The treatment plan is a multi-step attack. First, and most obviously, you get rid of the trigger. You stop the statin for life. Then, doctors use high-dose steroids to slam the brakes on the inflammation. After that, they might use treatments like intravenous immunoglobulin, or IVIG. This basically floods the body with healthy antibodies to block the bad ones from doing more damage. From there, it's about long-term meds to keep the immune system in check. And finally, of course, tons of physical therapy to rebuild all that damaged muscle. And the great news is, treatment can absolutely work. This quote comes from a patient who was so weak she needed a mechanical lift just to get out of bed. But after 6 months of aggressive therapy and rehab, she was walking again with a cane. It is a long, hard road, for sure, but recovery is possible. Okay, after hearing all of that, it is absolutely essential that we step back and put this all into perspective. The whole point here is awareness, not to cause alarm. We have to balance the huge benefits of these drugs with this extremely rare risk. And this slide has the single most important number to remember. The risk of developing this condition is estimated to be just 2 to 3 cases for every 100,000 people taking statins. Let me be perfectly clear, that is incredibly, incredibly rare. For the overwhelming majority of patients, the benefit of preventing a heart attack or a stroke far, far outweighs this tiny risk. So what's the bottom line here? What are the big things to take away? First, and I'm going to say it again, this is extremely rare. Second, the key thing to know is that the main symptom, that severe weakness, can show up months or even years after you start the drug, and it doesn't go away. This means getting the right diagnosis is everything. And all of that leads to the final, most important message for everyone. If you ever experience severe or persistent muscle symptoms, just have an open conversation with your doctor about it. And that really brings us to the future. Researchers have already found certain genetic markers that might put some people at a higher risk. And that leaves us with this really hopeful and thoughtful question, a glimpse into the future of personalized medicine. Could we one day use a simple test to screen patients who are at risk, to make sure that this life-saving pill always remains a helper and never, ever a mystery?